Good afternoon, everyone. My name is Avon, and today I'll be presenting a healthcare system that I decided for the United States. The purpose of this project is to look at what works at the other countries and use those ideas to build a system that improve access, lower costs, and increase overall health outcomes here in the United States. Since all of us here are consumer of healthcare and many of us will be working in healthcare, it will be important to understand how a system can be structured to work better for everybody. In this presentation, I will be walking through a key element that I've selected from other country, how the system is structured, how it is financed, and how providers are paid, what safety net exit, how drug pricing is regulated, and why this model would perform better than what we currently have today and right now in the US. Here is again is what I will be covering. First, I will be explaining which part of the foreign healthcare system that I choose to adopt. Then I will describe the structure of the new system, including what is centralized and what is decentralized. And after that, I'll explain the financing and payment models. I'll also decide the safety net, and who they are protecting. Then I'll explain how the drug pricing regulation work for the system. And finally, I will also be summarizing what this model improve quantity, decrease costs, and increasing access. Let's jump right into it. Oh, I'm a little bit ahead. To decide a better system in the US healthcare, I look at the four countries that we have been discussing through Yellow Dick, United Kingdom, not a lot of them, but we did touch base on some of them in the lecture, Germany, India, and United States itself. Each country has strengths that can help us fix weaknesses in our system. When it's come to the UK, I adopted the idea of the universal basic care funded by taxes. The National Health Service shows that tax-funded care can guarantee access for everybody without complicated insurance rules. When it's come to Germany, I adopt the shares, insurance, contributions, and strong regulation. Germany has a system where employers and individual both contribute and the government regulates prices and benefit. This would help keep costs stable. And when it's come to India, I see a strong primary care and use of community healthcare workers. India use community health worker to reach rural, unreserved area, which is something the US still struggle with. Personally, and this is just a personal information or personal side notes, I live in a very rural area in Barstow. Um, I work from home, so I do recognize my privilege, and I do recognize that because my work from home is a W-2 as well as a commission position. I'm a licensed insurance agent. So with that being said, I am very privileged. Although my privilege come to a certain degree where I would be able to travel using my vehicle out of the Barstow area to seek healthcare that would actually be good for me. Services is a little bit better. And this is just personal example. I used to seek OBGYN in Barstow. However, no matter how hard I try, it's very difficult to find a clinic or a provider that is up to a good standard. Um, I used to not trust rating when it's come to patient ratings or Google ratings or anything like that. But now, living here for quite some time, I come to trust them because majority of the provider around here, the most I'll ever get is 2 out of 5 stars, or at most they'll get 2.5 out of 5 star. And I did end up a couple years back, I end up finding a provider who's actually was pretty good, pretty decent. But the staff in her clinic is horrific. So that's just a whole another story, and I won't want to keep it any longer than that. But I do recognize my privilege. So back to my original point is the privilege that I have is getting insurance through my work. A lot of people around here don't have that type of insurance. Most of them are on welfare. Most of them are on Social Security. And you would think that because they are on Social Security, on welfare, the government would take care of them. But in actuality, it's not that at all. If you're not familiar with a social network app called Nextdoor, you can actually widen your search to be able to see posts from Barstow community where they actually, there's people who still go up to the posts and ask people for insulin if they can get them some cheap insulin. There's people who would post something the other day that would ask for inhaler, like asthma inhaler. So that's not something that the US is doing very good at. So with that being said, why would India be something that would work, especially in a community like Barstow in the US, Barstow, California? Because a community worker in the rural area would come out and help people who are struggling, who could not afford healthcare. That's my tension when it's come to Barstow and where I live. And from the United States, I would keep the advanced technology and the specialty care. The US leads the world in innovation, and that's something is worth keeping. But the disparity between the people who can actually afford healthcare versus people who could not afford healthcare, or even if they could, insurance is still something that could not bridge that gap. So to combine these strengths together, we can build a system that is fair, efficient, and innovative. So let's go ahead and move on to the next slide. A little bit ahead of myself again. When it's come to structuring the new healthcare system, I would like to explain how a new system is being structured. This system use a hybrid public and private model. The government would guarantees a universal basic care for everybody. This would include primary care, emergency care, essential medicines, and preventative services, which is what majority of current private insurance is already offer when it's come to preventative services. These services are funded through tax. So if you take a look at the Medicare system, that's how I know about it. They are already funded through tax already with the preventative services. If you ever get a chance to look at any of the Medicare plans or Medicare service in any area, most of the preventative are zero. When it's come to anything that is private, not all of them are being funded, or not all of them are zero throughout. Private insurance would still exist to some degree, but it is used for faster access, more choices, or premium services. And I would use the example of a Fast Pass in Disneyland. If you pay for Disneyland ticket, which is that's another way for us to saying that if we paid our taxes, that will fund our entrance into a healthcare system. But when it's come to getting in line in Disneyland to ride the rides, it's going to take a bit of time. So the fast pass would ensure that people who want a faster service or faster access, they will be able to have that options. Is there if they want to. But in guarantee, everybody will have healthcare. This keep innovations and competition alive without blocking any access to any basic care, i.e. preventative services. Central government set the national rules that would still stay, standards and benefits. This would ensure fairness and consistency across the state. However, with that being said, state managed hospitals, clinic, and healthcare workforce. This would allow flexibility because states understand their population better. Primary care is the foundation of the system, which is as it should be. This means every person have a primary care providers who would coordinate their care. The WHO, which is the World Health Organizations, have shown that a strong primary care leads to a better outcomes and lower costs. And let's move on to the finance and payment models. How the finance and provider are being paid is hospital are funded through global budgets plus quantity bonuses. This means that hospital will receive a set amount of money each year. They can earn extra funding if they meet quantity goals, similar to how CMS enforce STAR system on each insurance company. Every year, like we right now, I'm currently in what they call STAR season right now, where CMS will send out tester and they will dial us at the moment of notice. We'll pick up that phone call. We'll treat it like a regular system, regular customer call. If we pass all the criteria, we'll get extra funding. And with those extra funding, we can reinvesting it back into the plan for additional services, additional benefit through for our customer. And that's how they actually funded those grocery cards for people on Medicare and Medicaid, or the grocery card for people who's have chronic conditions. It will work similar that way. So if they meet a certain quantity, certain goal, they will earn money. And that's how they will be able to keep the funding. This model is used in country like Canada to help reduce unnecessary spending. Doctors or providers are paid through salary plus performance incentives. This would reduce pressure to order unnecessary testing or procedure. Instead, doctors are rewarded for keeping patient healthy. Insurance is funded through taxes and income-based premium. Higher income individuals contribute more, while lower income individuals pay less or nothing. This reduces financial barrier and lower out-of-pocket spending. Overall, in general, this financing models reduce waste, rewards preventions, and protects family from high medical bills. Now let's move on to safety net, which is an important part of the system. Oh, I'm a little bit ahead of myself. Let's go back to safety, which is again is an important part of this system. The goal is to make sure that vulnerable population are protected. The safety nets cover low-income family, like elderly adults, children, people with disability, and rural communal area. These services offered include primary care, emergency care, essential medicines, preventative services, maternal and child care. These services are free or low cost for people who would qualify. This approach supports universal health coverage goals and reduce medical bankruptcy, which is the major problem in the current US system. By guaranteeing essential services, we would reduce the health gaps and improve a long-term outcome. Okay, now here is the one of the important part, which is the drug regulation and pricing. Because a lot of people who have medical condition, they cannot afford drugs or medical necessity. Drug pricing is one of the, oh, again, I'm ahead of myself. Drug pricing is one of the biggest driver of healthcare costs in the United States. We have a saying in our company is that doesn't matter what plan you enroll people into, the first benefit that people will ever use, especially when it's come to Medicare Advantage, with prescription, the first benefit that people will use starting on the 1st of January will be the drug benefit. And if there are ever any issues with the drugs, they will let you know. So the system would include regulation. An independent nation board regulates pharmaceutical pricing. This board would work similar to National Institute for Health and Care Excellence in the UK, United Kingdom. The government negotiates drug prices directly with the manufacturers. Essential medicines have price cap to prevent extreme pricing, similar to how they put a cap on insulin that for the Medicare patients, they will never pay more than $35 a month on their insulin supplies. Before drugs enter the markets, the board reviews its cost effectiveness. If the drug is too expensive for the benefit it provides, the board can require a lower price. The system also encourages generics competition, which is the US Food and Drugs Administration, the FDA, has shown to be one of the most effective way to lower drug costs. This approach will keep medication affordable while still supporting innovation. And why does this system work? Why do I think that this system works? And I think that it would work as one of the best model. I'm sure somebody might have something else that might be a little bit better, but I think it could be one of the best model because first, it's improve uh, quality. Providers are rewarded for good outcomes, not for doing more procedures or more unnecessary procedure. Strong primary care reduces complications and hospitalization. Secondly, it also decreases costs. Out-of-pocket spending go down because essential services are being covered. Global budgets reduce waste in hospital. Drug price controls prevent extreme pricing. Put a cap on it. Lastly is increases access. Universal basic care ensures that everybody receive essential services. Community health workers help reach rural and underserved area. Safety nets protect vulnerable groups. These improvements are supported by global evidence from the OECD and the World Health Organization, the WHO. By combining the best practices from multiple countries, this system creates a fair, affordable, and high quality healthcare model for the United States. It's a win-win for everybody. A little bit I have it myself. So in summary, and in conclusion, this healthcare system used the best idea from around the world is balance government responsibility with private innovation. It improves access, lower the costs, increases quality, it protect vulnerable populations, and make healthcare more fair and sustainable. This model addresses the major weaknesses of the current US system, creates a strong foundation for the future. So I hope you take into consideration of my healthcare system. And I genuinely thank you for listening and thank you for taking time with me today. And you have a wonderful day.